Smith sir, maybe you can just give us go ahead. We'll start then.
Now, Saujatya, you are running the show. Always.
No, that's okay. Okay, anyways, we are very fortunate today. We have a star-studded panel and a star speaker with us, and it's on popular demand because UP Singh sir is putting such interesting videos. So, sir will be speaking on echocardiography right from the womb to the tomb. So, and we all are expectant. Already, so many people have joined. So, over to you, UP Singh sir.
Thank you.
Thank you for this accepting our invitation. Yes, sir.
Perfect, sir. So I think we are here, okay? And fine. Is that good to go?
Yes, sir. It's audible, clear. It's visible.
All right. So direct coronary artery visualization, it is actually a challenge by, echocardiography because of many reasons. But I'll try to show you the coronary artery anatomy, coronary artery physiology, and various disorders which I picked up in last 3 decades of echocardiography. And by seeing these pics, you would believe me that, okay, coronary arteries can be seen. And if you get something, free with an echocardiography, you are looking for a regional wall motion abnormality, then you have a coronary artery visualization and you see something there, it's an additional free gift to you, but utilize that free gift. Okay. So I would be telling you about fetal anatomy in coronary artery disease. In the pediatric group, I would cover a couple of AV fistulas, and I would touch upon Kawasaki disease, which itself is a big chapter, but I would give you a glimpse of that. And adult, I'll show you both atherosclerotic and congenital coronary artery abnormalities. We do understand once we are doing an echocardiogram, then we have 3 orthogonal planes where we can actually use both short axis views and a long axis views like this. And, you must believe that, I think you do, coronary arteries are spread in a 3-dimensional format across a kind of a circular heart. But what do we get on a coronary angio is a flat surface, 2-dimensional thing. Even if you do a 3-dimensional CT, you would still see it in a single dimension, all things projected from, and you actually try to differentiate from each coronary artery by changing views, trying to avoid the overlap. But you are putting all those 3 dimensions into a single plane. It becomes very easy to see the anatomy. But in the 3 dimension, you have to move your probe, work in 3 dimensions to get those anatomy. And that also would come piecemeal. It would not come as holistic as you are seeing on the coronary angio. I think I'll spend about 5-6 slides on explaining you that what should be your approach when you're doing an echocardiography, what changes you should make in your presets so that you are able to see the coronary arteries, which are small, about 3-4 millimeter in diameter. They are moving, and with the movement, you get artifact in the color Doppler because of the wall motion. A color Doppler is produced, which masks the true color flow in the coronary arteries. So these are the changes which we expect to make. They're a long list, but I would touch upon very few. Most important thing is a dynamic range. Go and reduce dynamic range. A smaller dynamic range means you see black and white, and more dynamic range you increase, you see shades of gray. These are things which are very, very important in case you are looking for a tissue characterization. But we aren't interested in tissue characterization here. We are interested in a tissue and a wall or a surface interface. So if you want to see the interface, lower the dynamic range, better you would be. So if you have a higher dynamic range, you get a far greater characteristics of the tissue because lot of grayscales are available. But as you reduce the grayscales, go down, and you can see very contrasty kind of an image, and that's what we should be looking for in a coronary artery. Then you have to reduce the velocity scale. The velocity scale of less than 20 is a kind of ideal for coronary artery because the flow velocities are low in the coronaries and you can't have a high Nyquist limit. Then you would miss the coronary artery flows and you reduce the Nyquist limit, but you create a mess out of this flow. So how do you actually try to get something out of by reducing a Nyquist limit? That next few slides I'm going to show you. What you do is that it's a good idea to have a side-by-side 2D, understanding that once you have a color Doppler, it might mask the underlying 2D. You need something for the reference. So putting a 2D alongside the color Doppler does not reduce any frame rate or does not improve fall in the resolution. So, but what you do is that you try to look at the coronary artery and you freeze somewhere here where you see the right coronary artery and you see the right coronary artery flow, and this is different than else. This is something you need to do once you are looking at the loops. Other things to improve from there, what you saw is that you increase the line density, find out in your equipment where is the line density, then increase the packet size, increase the now if you increase the density of the lines, you would see structures far better, but at the cost of drop in the resolution, temporal resolution, because the frame rate would fall. You increase the packet size. Again, by increasing the packet size, you improve on a color gain, but you would lose on the frame rate. Ensemble is something very interesting. In ensemble, you expected that a single wave is sent across the line when the transducer is transmitting the ultrasound waves, but actually it is about 2.5 waves are sent like a train together. And if you increase this number of trains together, this is called an ensemble. Increased ensemble also would improve a color mapping. So these are three things what you can do. There's something which probably we don't look at very frequently. Now this is called a balance or color priority. What is the balance? You always see this kind of a color bar along with. You see the color bar, you see a 2D. We never knew what this 2D means along with this color bar. This means that in case you take this marker up, which comes from a toggle button where you can increase or decrease the balance between what is the balance? What amount of information on the 2D, whether if you want a priority for the color would override the information on 2D, which is underlying. And if you give less priority to the color, more priority to the 2D, the color become more transparent and you see a 2D behind, which is thing which you don't want to do. For example, this is a carotid Doppler, and this is where you have the priority, you see the color fill, but in case you reduce the priority of the color, you give more priority to the 2D. Now the color doesn't fill well, and you get a lot of 2D information which is there on the background, which here it was overridden. So then this is what you should do when you're looking at the coronary arteries also. And last thing which I want to tell you, to increase the smoothness and persistence of the color. Persistence is how many frames the same image persists. Let's say for 2 frames or 3 frames. So your color remains there for a little more longer while. And for the smoothness, it increases. Now, normally, once you have one pixel where the color is there is another pixel. The computer or the system actually generates the gap in between two into a color also gives a smoothness. The things I didn't think that I would not go into detail. In our equipment, which I'm using, Philips, there is already a preset by the name of Coronary. You go and find that Coronary preset, and you're all good to go. So these are the settings which I generally keep on my, you can have a screenshot. These are the settings for an equipment where you want to see coronary arteries or low flow patterns. Another thing which you can use in explain of the 3D, where you have an explain, is that you get absolutely perpendicular plane to the current plane. So you are on the cross section, you see the coronary artery here, and if you put an X plane, you get a 90-degree of the same plane, and you see the coronary artery in a longitudinal view. And that's what here we see. We put the cursor here, and then you see a small coronary artery here. You don't see things very well here. Let's go further. Excuse. We are not too good to look at the coronary arteries, but if you talk about proximal coronary arteries, LAD and RCA, reasonably good. So even if you pick up the proximal RCA and LAD, I think it's good enough. You've done a good work. Let us see coronary arteries and how do you see it. Left main, proximal LAD, RCA, and this. So you go to a standard parasternal short axis view, and then you go a space higher. And this is what you see. And that's, you've been doing it regularly. That's the right coronary artery, and that's the left coronary artery. Then you can see the right coronary artery. Again, the left coronary artery. Left coronary artery again, proximal left coronary, and then it's dividing into LAD. That's an LAD which crosses an RVOT. And here you see short left main dividing into LAD and circumflex, which is seen in blue. Left main is something very important, and if you have a left main disease, it can be picked up in more than 55% of the patients. You can get aliasing there in case the stenosis is more than 50%, and left main disease can be picked up with an accuracy of over 80% if you are vigilant enough and using to see coronary arteries more frequently in your day-to-day practice. This is another apical five-chamber view or LVOT view where you see the left coronary artery and the right coronary artery emerging. Now, mid-segment. Mid-segment coronary arteries are a little tough to see. Mid-LAD, you move a little lower down. I think I'll just show you that. Let's go not talk about the theory. Okay, now this is a patient, which a case which I would show you. This is and circumflex artery, which was in the AV groove. That's the calcification there. And this is where you get flow aliasing, which indicates the velocity is more than 75 centimeter per second, which is a high velocity. I must remind you here, 75 on a color Doppler is a mean velocity, not the peak velocity. Color Doppler always represents mean velocity. 75 is the mean velocity, not the peak velocity, right? And then you can have the branches of anterior marginal from RCA. But I think I'll show you cases that would be better. Now, let's see, how do you see the proximal? It is interposed between the RVOT and a pulmonary artery. It is quite difficult to see because the RVOT is quite dynamic, and it swings the coronary artery, left coronary artery along with. And that is an LVOT. That's the pulmonary valve. This is the pulmonary artery, LVOT flow. And you see the coronary artery. This is proximal LAD. Incidentally, you see small blue color also, which represent associated coronary vein. Around you can go, and this is a mid LAD in the middle part of the interventricular groove. Again, you see a vein associated with it. Then you have a same mid-segment LED. And then is a distal LED. We are close to the apex. I think, guys, just keep watching it for a while. Let me have a glass of water and come back. Yeah, sorry for that. Okay. So now let's move to the next slide. Flow in the coronary artery. Once you've seen a coronary artery, I would show you a few cases. And, this is a step ahead. When you are not only visualizing coronary artery, you are actually trying to see the Doppler signals there. And we should know that the Doppler signal predominant circulation in the coronary is in diastole and a small systolic. And it's kind of a continuous flow. And you have a diastole and a systolic is lower than that. But it happens otherwise in the intramural artery where it's systolic is there is a reversal and the diastolic flow continues. And in case you have a systolic diastolic ratio which is obtunded, this would actually indicate a proximal occlusion of the coronary artery. I would show you the example. Distal LED, you are close to the apical four-chamber view. You are from the basically, if you acquire a two-vessel view and angulate slightly toward the right side, you would get this coronary artery distal. This probably was the first way of looking at the coronary arteries people did. Many times, you get something which helps you see coronary arteries better. One of the situation is that when you have a pericardial effusion, you have some interface between the heart and then you can see the surface is filled by the fluid. Then you can see coronary arteries, and that's a coronary artery, which is LED, which is running in the, this is, posterior descending artery, because this is a posterior AV groove. And same, you can see it in color. You can see in circumflex artery, that's a circular artery which is going in the AV groove. And then again, the coronary artery. You may be lucky again in another situation where there's increased blood flow across the coronaries, and one of that is hypertrophic cardiomyopathy. These are the septal branches which are going into the thickened this thing, a large multiple septal branches obviously would tell you the septal ablation would be a bit of a challenge because it's not a single septal. There are multiple large septal branches going through the thickened interventricular septum. Can we see coronaries in the fetus? Yes, we can. And that's a fetus about 26 weeks of gestation. This is aorta, and you can very clearly see the right coronary artery right throughout. So you need and mission, then you would see the coronary artery. So now you can see the posterior descending artery. Posterior descending artery is a two-chamber view, LA and LV, and then you see the posterior interventricular groove, and there you see this coronary artery. This is markedly increased flow in the posterior descending artery. This was the patient of L kappa, which I'll be showing you shortly. But otherwise, looking at the posterior descending artery, which is usually small, is difficult. Then when you are looking at the coronary arteries, then there are certain mimics there. You presume that this is a coronary artery, right? But see, the color is blue. It's going from apex to the base. So either it's a vein, or there is an obstruction of the coronary artery here. The blood is going backward. but it's actually not the coronary artery disease. This is one of the recesses what we get in the non-compaction of the apex. And these recesses, many a times, if you are a little angulated, you might think that this is a coronary artery. This is right coronary artery, the left coronary artery, but you see a space down there. So this is the transverse sinus. So this is a normal where there is a mild pericardial fluid, which you can see, and you might think this is a coronary artery. Another caveat, and this is very common caveat, what we see, you see a tram-like structure, and which is hyperechoic edges and very fixed linear, which is crosses the AV groove in this direction. This is again a pericardial reflection of the AV groove, and this is not the posterior descending artery or a right coronary artery. The differentiation is if you have a bright structure right throughout the line, and this bright reflection comes from the pericardium. Let's see the cases. The very first case is normally we expect the right coronary artery to arise from here, but the right coronary artery is arising from this place. And when we did the view where we get left coronary artery, we did not get the right coronary artery in the same plane because it was a higher takeoff of the right coronary artery. And that's just a representative diagram, not of this case. So I think if you know this, maybe you would know what hardware probably you would need once you're going to do a coronary angio. Now I'm going to show you that case which I showed you. This is a short axis view here. You see one papillomamus or another one and a part of the mitral valve, but you see the septum and anterior posterior walls are moving perfectly fine. The lateral and the anterior segments aren't moving good. And secondly, you see again the lateral wall is not contracting well, and there is an LV dilatation. This means that this is the territory of left circumflex. And once you see the left circumflex in the posterior interventricular groove, where you have a left dominance where the PD was supplied by circumference, and then you see there is a serious stenosis. You see ileasing, which I showed you. And this is the normal flow which you had expected in diastole and in systole, but that was we put the pulse Doppler in this situation, and this is what the flow we got. Look at the velocities crossing 1 centimeter, which is again a cutoff limit for saying that this is a stenosis. And remember that we are actually not parallel to the flow. You need to have more angle correction. So probably this velocity would be more than 160. And see, this velocities are more in systole, which again is not the feature. The diastolic velocities are less. In fact, in diastole, we are getting an early diastolic flow, and we are getting an A wave, which again is very uncommon and characteristic of a coronary artery obstruction. You see a proximal LAD. You see some ileasing here and irregularity, some area of dilatation. We were suspecting there is a stenosis in the proximal artery. The distal artery was fine. And remember, in case the distal artery is showing a good flow, this is distal LAD, which is showing a good flow, which indicates that the obstruction is not very severe. We put a pulse Doppler sample, and we got the velocities which were high, but still the diastole was maintained. The velocities went right up to 2 meters per second, which indicated significant stenosis. And once you do a Doppler of the distal LAD, Doppler shows equalization of both systolic and diastolic waves, which is an indicator or a marker for a proximal obstruction. So we have a proximal LAD disease, which is produced here. So we got lucky, and we could get these kind of things when you're doing. And now this is 72 years hypertensive male who had CKD CRAT of about 4 and EGFR of about less than 30. He presented with history of dyspnea class 2 for last about 3 months, and there wasn't any angina or on exertion. LV functions were poor, and the LV functions were somewhere around 20% ejection fraction, and so was the global hypokinesia on a cross-sectional view. So there was no regional wall motion abnormality, but once we are scanning the coronary arteries, you see there is a dilatation of the coronary artery, which was more than 4 millimeter, and that is a left main and the LAD here. This is LVOT, this is aorta. Now you have the artery crossing LVOT and going, and this is the LAD, this is left main. And in case you see a circumflex artery, that also is dilated and going posteriorly. But apart from that, if you see other arteries, do you notice a small artery here? Now this artery is OM branch of LAD, right? LAD is somewhere here. This is an OM branch, and this branch is narrow. You have a posterior descending artery, which is also small. You have another artery, which is again small. This patient had a ectasia of the left main and LAD and diffuse triple vessel disease, which was left to medical management. And the same patient, this is the left main, you had some occlusion somewhere in LAD, and you can see a collateral filling the distal part of an LAD, but I think that is a little challenging. I'm going to show you L kappa, which I showed on my YouTube channel, and it's, you guys know it, it's Singh. And the origin from L kappa is the origin of the left coronary artery from the pulmonary artery. I mean, it shouldn't be called origin, should be drainage, because once the PA comes from the pulmonary artery, the pressures are low, and then you get a left to right shunt from RCA right back through the collaterals and LCA and into the pulmonary artery. And that's what we see. I mean, there's a big name given to it. This patient had dyspnea on chest exertion and then had a cardiomegaly. There was an angina and dyspnea, cardiomegaly, and even plethora, which indicated then more than left to right shunt. And you can get a typical R wave poor progression on the ECG. This is a rare congenital abnormality seen in adulthood because 90% of patients do not survive the first year, and then 90% they present in the first year only, and out of that, the commonest symptoms being heart failure and sudden cardiac death. So that's the patient where I was talking about, lucky enough to survive till that, the enlarged left atrium. Then you have a large left atrium indicates two things. One is the diastolic function abnormality of LV, as well as increased left to right shunt. When you have more left to right shunt, the LA gets enlarged. And then there is a global hypokinesia, and that's false tendon, what you see in the LV. Now you see the papillary muscle scarred and calcified. That's again because of the blood supply to the papillary muscle also is jeopardized. And if you see in the same view and you pay attention, you see there is in the interventricular groove on the right side, you see the right coronary. This is atrioventricular groove. You see the right coronary artery here. Okay, so you see the right coronary artery, which is definitely enlarged. And then on a color Doppler, you see a very enlarged furrow in the right coronary artery and atrioventricular groove. And you see some regional wall motion abnormality also. And you see not only that, you see myocardial scarring and calcification close to this papillary muscle area. Now, on the color Doppler, on a short axis view at the aortic valve level, you see a very dilated, enlarged right coronary artery. And then if you follow other coronaries, you see specks of coronary artery flows all across the lateral wall of the left ventricle, which indicates increased flow through those collaterals. And that's what I showed you in my first video. You see posterior descending artery also is markedly dilated because now it would get connected with the left circulation. And once it connects to the left circulation, and this is what you see the, sorry, see the left circulation. That's an LAD which is tortuous, which is entered into the pulmonary artery, and this is that unexpected towards the probe flow, red flow. That means the flow is coming in this direction, like you would see in PDA. And this is because the LAD is actually opening on the lateral aspect of the pulmonary artery, and that is L kappa in the adult. And this is the investigation of first line or a choice where you can do CT angio and see the great anatomy, but many a times you need to know the detailed anatomy of uh, and enlarged coronary arteries, collaterals, and filling the pulmonary artery from there. I'm going to show you a fetal prominent coronary artery. You see a fetal prominent coronary artery just to tell you the anatomy of the fetus heart. This is left atrium, left ventricle, LVOT, and this is aortic flow. This is the right atrium, and you see some flow here. We would come down to that. This is the right ventricle, and that's what coronary artery prominence you see. And then you see this blood flow going right from there to the pulmonary artery. In the fetal circulation, the PA and aorta pressures are same because RA and RV pressures are same because of fossa valis and the patent ductus arteriosus. And this is what you see, a to and fro flow in the coronary artery, which is opening on the lateral aspect of the pulmonary artery. So that's what is a little magnified view of the same. You can see another arterial branch coming and joining here. Or this is a branch of an LAD. They probably the left main, an LAD and circumflex, which is coming from the pulmonary artery. I won't go into the details of the surgery which are required. Now I take you to a couple of more cases where I'm going to show you the coronary artery to RA, to LV, to RV fistulas. I would show coronary artery to pulmonary fistula. I would show coronary artery to pulmonary vein fistula. The vein is missing here. So pulmonary vein. So three things I'm going to show you. The very first case. Okay. The very first case you see here. Now, what do you see? The left atrium, not much enlarged, left ventricle, LVOT, and this is aorta. This is the aortic valve, and this is where the right coronary artery arises. At the first place, we thought this is the dilated right coronary artery, which I think you all would feel that, okay, this is the right coronary artery, which is markedly dilated. And then you have, but you see some flow which is coming from here. If I stop and show you the video, this is not filling from here. The right coronary artery would go like this. It is something like this. This is the retrospectively, we initially thought that the right coronary artery, which is leading to the fistula, but on a coronary angio, it was the left coronary artery. And this is on retrospectively viewing our we did give a diagnosis of right coronary artery to right atrial fistula, but it was LAD to right atrial fistula. And what a trick was doing, the LAD was actually circling around and going anterior to the aorta. This is LAD and this is going posteriorly. See, this is LAD and this is going posteriorly. This is circling like this. So now the case in detail. LAD. Now LAD, the blood is going back into posteriorly. Done. From here, the next step is it from LAD, it comes to the right side. Here it has come on the right side. From LADs come on the right side. From here, it is going posteriorly and opening somewhere here in the right atrium. And once it opens in the right atrium, it is actually showing you this is a large fistula, prominent kind of an aneurysm. The reason being there was a stenosis at the opening of the coronary fistula. And this is what we saw at the end. The right coronary artery, this is the left coronary artery coming down, opening into the right atrium and producing continuous flow in the right atrium. And that was an angiogram which was done by Dr. Rohit, Professor Rohit Manoj in PGI. And that is the left coronary artery. And that's how we went back and said, oh, we thought it's a right coronary, but it was the left coronary artery, which is dilated. You see this big aneurysm kind of thing. There are two blobs here. And then you have an opening which gives a continuous flow of blood into the right atrium. Sir, I had planned to do coil embolization of this in two stages. One stage was not successful, and second stage, I learned that patient didn't report back. Maybe Dr. Rohit would comment on this later. Now, this is the next case. What do you see here? This is an aorta. This is an LVOT view. Then you parasternal long axis view. This is LA, and you see the LV ejection fraction is around 40%. It's not contracting normally. You go to the second view, and you see LV is not contracting well. And what you see here, the RV is also dilated. There is both mitral and tricuspid regurgitation, which are a moderate category. But something very interesting happened. What we saw here, normally you don't expect a blue color flow from RV going down toward the right atrium. What is happening? Normally you expect like this. You expect an antegrade flow. Okay. So here is, I'll stop this and show you. There is an antegrade flow here. This is what we expect. We expect an antegrade RA to RV flow. But if you see here, it is a flow which is going back. So what is happening? Okay, let me show you next. Okay, what is happening here? This is parasternal view. If I angle it slightly medially, you see from the aorta, a large artery is, something is coming from here going in the interventricular groove at the anteroseptal segment, and it's going toward the apex. You see this vessel again. Incidentally, you see a cross section of the pulmonary valve, and which is pulmonary valve is tri-leaflet. So tri-leaflet pulmonary valve, but that's besides point. You have an aorta, and this is large vessel which is going along the anterior septal segments toward the apex. Okay, and the same. And in here, not only that, you are able to see the left pulmonary artery. Now, in this case, now here is the cross section of the pulmonary artery of the aorta, and this is the left coronary artery, left main, LAD, which is markedly dilated. You see this? This is the aorta, tricuspid valve, cross section, and that's the pulmonary artery. And here you see crossing the RVOT is left main and LAD, which are markedly dilated. It's about half the size of the aorta. Now here, what you see is that the same flow of blood. Okay, let me, all right. Now you see the same blood of flow going, this is the aorta, and the blood is going from aorta right. So this is a left anterior descending artery, and left anterior descending artery is taking a turn. And from here, it is entering into the right ventricle with a wide opening. It's as wide as little bigger than half the size of an aorta, producing a large shunt. This was a 5-year-old child where surgery was done. Okay. I'm going to take you to a mom, and that is a 23 weeks gestation. And there was a flow reversal in descending aorta and in ascending aorta. Okay, and there was no AR. Why there was a flow reversal? Okay, let's see that. This is, let me give you an orientation. That's the spine. Because of the spine, which is anterior, there is shadowing and we are not getting a very good view, but it's still fair enough. This is the ascending aorta. This is the transverse arch or aortic arch, and that's the descending aorta. You see, this is the descending aorta. This is the inferior vena cava. Now, this flow here you see is both systolic and diastolic. It's flowing this side and the other side. Now, this is a systolic flow and a diastolic flow reversal in this, which indicates there is some flow reversal. Why should there be a flow reversal? This is an aorta and the pulmonary artery on the side. You see to and fro color Doppler, which indicates that there is flow reversal, but you don't see any aortic regurgitation. So what's happening? Now, what you see here is that there is an aorta, and then you see this is a coronary artery, the right coronary artery, which is going in the groove, and you would see on the color Doppler. So that is where the blood was all coming to. It was actually regurgitation. There was no aortic regurgitation. There steel was happening in the right coronary artery, and with that steel, this was the opening. If you could notice this opening of this is pulmonary artery, and then this is the opening of that coronary artery into the right ventricle. So this was a coronary fistula into the right ventricle from the right coronary artery. I mean, a very similar picture would come with the aorto-RV tunnel. We lost follow-up. This child was born normally, was followed up in PGI, but could not have a feedback that what was actually there. Fetal coronary AV fistula. This is a fistula with the circumflex artery. This is the fetus of 20 weeks of gestation. Mind you, size of the fetal heart at 20 weeks is size of an almond. So seeing a coronary artery is a challenge. Now you have a left circumflex artery which goes behind the right atrium and opens into the right atrium, forming an AV fistula. And on this side, you can actually say the similar kind of fistula which I showed you in that adult patient left coronary to RA fistula which I showed in an adult. So this was a circumflex to RA fistula of a similar nature. Now, can we have a coronary artery to pulmonary vein connection? This is the patient. This is, I think, 2-year-old child. Look at the fossa valis, which is bouncing on both sides, indicating the pressure in RA also is high. RV is markedly hypertrophied, dilated. So is the right atrium. Left ventricle contractility is fine, but the RV contractility is not good. You have LV contractility also poor. Once you see in the parasternal long axis view, you see a moderate mitral regurgitation, and you see the LV contractility is poor. And that, I think, was not related with anything else. This was a fistula, what we saw, which was unrelated to this pathology. See, this is a coronary artery. This is LAD, and then this LAD. Okay, I'll show you what is happening. The LAD is going up. and then it is coming. So this is one. You see this LED going up, then you would see it makes a hairpin and comes down. Once it comes down, it crosses the pulmonary artery. It doesn't open, it's just overlapping the pulmonary artery and then opens into the pulmonary vein. So it opens into the pulmonary vein. Okay, I freeze this in different frames. I just combined the frames to make you understand. Aorta, LED, from LED it loops. This is the AV communication which we have, and this vein, pulmonary vein opens in the coronary vein, open into the pulmonary vein, and this is right atrium. Now you have a coronary artery PA fistula, which you probably would have seen a good number when you're doing a coronary angio, or on an echo, it's not a very common phenomenon to see. You see the flow coming into the pulmonary artery, and if this is the coronary artery which you saw here, but if you improve the resolution of the equipment by the method which I told you, you can see to and fro blood in the coronary artery, which was actually opening into the pulmonary artery. It was small. In the pediatric population, the Kawasaki disease is a problem where we need to see. This is the only good indication to look at the coronary arteries in the child where the fever is more than 5 days, and there are certain criteria. The child can have a rash, conjunctivitis, and oral as well as hand and feet issues. When there is a scaling there, that is the time when it is suggested that fetal the pediatric echo should be done. The idea is to see the kind of either fusiform aneurysms or a global kind of an ectasia. And this happens in 20% patients, those who have Kawasaki disease. And 80% of these aneurysms can be detected on an initial exam, but we suggest that it should be followed in 3 to 4 weeks and maybe again after some time, because 20% would appear, aneurysms would appear later. You can have a coronary artery dilatation with a Z-score of more than 2.5, or the absolute diameters are more than 3 millimeter or 4 millimeter in age. These are the guidelines from Asian Pacific Society of Cardiology. And these are the guidelines for Kawasaki disease. You should classify coronary artery aneurysms either by using Z-score or pragmatic method. What does pragmatic method means? I'm going to show you. These are the Z-scores from various authors. We'll not go into detail, but that's a good handy calculator which you should use for the Z-score. You can use any of the Z-score you wish to from there. But you can either use a Z-score where you have a dilatation of the coronary artery, or you have an aneurysm which could be small, medium, or a giant based on the Z-score. It's important because when the child grows, the Z-score, the coronary artery also grows. So Z-score gives you a good reference when you follow the coronary aneurysm in future. But you can actually may not go into the calculation. If you see there is a dilatation from the proximal segment, which is more than 1.5 times the proximal segment, then you can always say there is a dilatation of that segment, and that also amounts to an aneurysm formation or dilatation of the coronary artery. I just show you one example here. That's the right coronary artery, which is dilated. I've shown you right coronary artery previously in one of the videos. Yeah, so that's the right coronary artery, which is markedly dilated. Then you go ahead and you see again the right coronary artery and its two branches, which you see as a marked dilatation or aneurysm. Now you see the left coronary artery. The left coronary artery also is aneurysmally dilated. Now this is the left main, left circumflex, and the LAD. There is an aneurysm and LAD. And left main and circ are dilated. So same here in the LAD. You see the LAD and now this is the large aneurysm of the LAD and the proximal part of the circumflex in a patient child with the Kawasaki disease. And you can take the measurements of that. The measurement should be from inside to inside border, and you can use a Z-score to know whether the coronary arteries are dilated or not. In the Kawasaki disease, about, 60-70% happens in the proximal part, and distal coronaries are less commonly involved, fortunately, because we can pick up abnormalities in the proximal coronaries far easily on echo than distal ones. You can have about 1/4 of patients having left main and circumflex. So that accounts for about 50% of the aneurysms. Another 50% is a proximal RCA and little distal RCA. So this accounts for about 60 to 70% of the aneurysms in the proximal part of. Can we have prominent coronary arteries in the fetus? Yes, we can have. There are three situations. One is increased flow in the autoregulation. Once there is hypoxemia in the fetus because of any reason, congenital heart block, or there is placental insufficiency causing IUGR. In all those situations where there is a flow problem across the coronary arteries, the saturation drops. And then when the saturation drops, there are three circulations which are preferentially given more blood. One is brain, second is heart, and third is adrenal. So there is a redistribution of the blood in these three organs. And this redistribution, because of autoregulation, makes the coronary arteries very prominent in many situations in the fetal circulation. Secondly, when we can have situations like hypoplastic left heart syndrome, we can have pulmonary atresia or intact ventricle septum, which you can call it a right heart syndrome, hypoplastic right heart syndrome. In these two situations, you can have the collateral circulation, which takes the blood from the hypoplastic ventricle into the aorta, right? So that's the egress of the blood from the hypoplastic ventricle. I would show you an example. Then the same coronary AV fistula in the kappa, which I already showed you. So I'm going to show you two reasons. One is an increased flow because of autoregulation. We understand because of the low oxygen tension in the blood flowing in the fetus, you have less of extraction of oxygen as compared to the neonate. In case the oxygen saturation falls further, the only respite fetus has is to increase the coronary artery diameters, hyperemia, to actually increase the oxygen delivery or flow in the coronaries. So these are the coronaries which you can see in the fetus. So this is, you see the coronary artery, the right coronary, and the blue one, the left coronary, marked by the arrows. And these are the coronary arteries which are very prominent. These are normal. This is about 30 weeks of gestation. This patient had an IUGR, and you can see the coronary arteries are very, very prominent. On this side also, you see prominent coronary arteries, and that's not a very rare phenomena we see in the fetus. Now, other situation where the coronary arteries can be prominent is hypoplastic ventricles. In the hypoplastic ventricle, the blood from the ventricle where the aortic valve is actually atretic, and the blood, whichever small quantity is coming into left ventricle through the left atrium, has to go somewhere. It can either go back by mitral regurgitation, or through the collaterals, it can go into the coronary artery and then into the ascending aorta. And that's what we see in this situation. So these are the coronary artery collaterals, what you see in this hypoplastic. Let me show you an anatomy. Right atrium, right ventricle, which are large. Left atrium is small. This is the left atrium, this is the left ventricle, which is very small and globular hypoplastic. And these are the coronary, prominent coronaries, what you see in these group of patients. And these are actually a bad sign, because if you have this, the surgery success rate becomes very less, because the coronaries would be affected when the surgeries are going to be done. This is the right ventricle. This is again a patient with the hypoplastic left heart syndrome. This is the left ventricle, which is small. The only flow you see in the right atrium and right ventricle, and you see a flow reversal. This is three vessel trachea view. You see the pulmonary artery flow is going this way, but the aortic flow is reversed, so that because the aorta is obstructed at its origin, and the flow reversal is there in the aorta, and you see these collaterals, right? Full left ventricle is full of these coronary collaterals. That's right. So this is the coronary collaterals which form an egress of the blood from the left ventricle. Thank you very much for your kind attention, and I always learn that still a lot.
Excellent, sir.
Thank you, Dr. Vijayalakshmi. Thank you very much.
A very good talk, Dr. Singh. It was a very ambitious thing to cover coronary imaging from the womb, the tomb, I wouldn't say, but certainly beginning from the womb and getting it across different age spectra and demonstrating that with intellectual curiosity, even in the regular adult coronary artery disease, you can derive information from what you see. But what I found most useful were the fetal images that you showed, and also the structural anomalies, the coronary fistulas that you showed. In the fetus, the normal coronary artery we seldom see. So we say that if the coronary artery is standing out, there has to be something wrong with it. And they have given some excellent illustrations of fetal abnormalities and fetal diagnosis, and the reason why we need to follow them up into neonatal period to establish a firm diagnosis as to your interpretations were right. Excellent talk, Dr. Singh.
Thank you, sir. Thank you.
So my only comment is your Al-Kappa was too good, and the hyperechogenic endocardium was very nicely shown. That is the point, because LV dilatation, reduced function can be there in any other condition. But because of the subendocardial ischemia, that hyperechogenicity or a glistening endocardium is a feature. And regarding your coronary AV fistula, I would have closed it with the device rather than the coil, because coils are little messy and the residual shunt will be there. And since I have closed all the aortoventricular tunnels as well as the coronary AV fistulas all with the devices, that would have been very easy to go from the RV side and close with the device. Excellent presentation, very nice, sir. And regarding your hypoplastic left heart, I had most of them, they die very early. I had one child presented at the age of 10 days, and I was surprised how it is surviving. It because the coronaries were coming from the pulmonary artery. And both the coronaries were coming from the pulmonary artery, and how to distinguish it? This pulmonary artery was branching. Wow. Aorta was hypoplastic and pulmonary artery was branching, and the coronaries were recurring from there. So that's why, in congenital, anything is possible, and we have to keep our eyes open. And I have always seen you keeping your eyes so open. You make our eyes also open. Thank you very much. Excellent presentation.
Thank you. Thank you. I don't know whether Dr. Rohit Manoj is here or not, because he was the person who performed or attempted that LAD to right atrial fistula, and there was a kind of an aneurysm because of an obstruction at the origin, and it was huge. And he did put a couple of coils and then called it for the second phase.
Sir, he was supposed to be here, sir. He was among the experts, but I think he could not make it.
Yeah.
So,
thank you, UP Singh. It was a very excellent lecture. right from the womb to tomb. I thought you were going to show some dissection also, because in one of your
All right.
one of your sessions in Chandigarh, we were given hot samples of some pigs, and we are asked to dissect.
Yeah.
I still remember. And Chandigarh is famous for postmortem and other things. Now, how do you correlate this increased velocity in the LED and other things with the stenosis? How many cases have you done this? And how many cases showed the significant stenosis in LED? I think left main you can pick up even in adults. But I don't know whether there is any correlation with the actual left main disease and proximal LED disease or proximal circumflex disease. Have you got any information on this? Because that will help all the adult cardiologists.
Yes, sure. See, I don't have my own data, but on the review of the literature, it did show that left main disease can be picked up in about half of the patients, 56 to be in one large study, that you can pick up about half of the patients of the left main disease on echo. But I think most of the times we are doing a conveyor belt echo. We don't spend that much of time to see coronary arteries, understandably because of the large volumes. But in case you start doing that, you would be able to pick up a lot of patients. I don't have my own data, but I would have 10 odd patients of coronary artery stenosis. I could not dig those patients. I would have shown there were 2 patients of left main with calcification at the origin. I don't know where those got lost in my big hard disk, so I couldn't. Maybe next time I'll show you that. But otherwise, for the very beginning, I remember Dr. Naveen C. Nanda presenting cases. The whole thing started when he started looking at the distal coronaries. There was a study which is published, and he all used to show you just do the pulse wave sample in the distal coronary artery, and from that flow pattern, you can always say whether there is stenosis. People have done the flow reserves by giving adenosine and so many things. So, I mean, we are quite far behind in the coronary artery visualization on an echo.
Will that help in deciding the treadmill test? Because routinely we do the treadmill test for coronary disease. So, will you say that echocardiographic detection of left main disease is a contraindication for treadmill test or stress test?
I think so. Because I do remember in one of the patients where we were planned to do a stress echo, exercise stress echo, we saw left main disease and we didn't do it. The gentleman had triple vessel disease with the left main also on an angio, but we didn't do it. But these are kind of, see, looking at coronaries gives you is a kind of a free gift what you get with the other data from the echocardiogram. We can't really say that we get a lot of information by looking at coronary arteries. The coronary arteries are there, once you're taking a pulmonary flow pattern. So look at the coronary arteries also. Where is the big deal? You are looking for, whether it's a bicuspid or trileaflet aortic valve. We try to do it in almost every patient. And then there you are. There the coronary arteries are, at least the proximal part, you can see it.
So you think that the biplane view will be a best view for studying the flow?
I would say that I would tell you about probably 2 or 3 views which are actually recommended in Kawasaki. Kawasaki, you have to look at the coronary. There's no other way around. There the echocardiography is a kind of screening standard. You have to start with that only. So there the recommendation is that you see a short axis view at the aortic valve level. You move slightly cranially, and there you'll see the left coronary artery going across the pulmonary artery and RVOT. Then on the right side, at around 11 o'clock position, you would see the right coronary artery emerging from the short axis view at the aortic leaflet level. Then from there you go a space higher to look at and follow the left coronary arteries. You have to move little more cranially to follow the left coronary artery. You have to go little caudally to see the branching left main and the left circumflex. Then on a little angled two-chamber view, you would see a distal left coronary artery, which is easy to see. So these three things are easy to see: proximal RCA, proximal left main, and occasionally LAD. Circumflex is little difficult to see, but then the distal LAD, it is easy to see on a angled two-chamber view, or it's somewhere between two-chamber and apical three-chamber view.
Now, in the ABCDE protocol of the stress echo, they say you have to pick up the coronaries routinely. Now, how many cases have you tried?
I've tried in almost
record the coronaries.
I think I've tried in many, but honestly, after delivering the talk, reviewing the literature, I would be doing more.
In the post-stress situation, you know the images are not that good. Can you pick up the coronaries as they suggest in that ABCDE protocol?
I don't think so. We can, after the exercise stress echo, I really don't think so. On a peak exercise, I would be able to pick up any coronary arteries. The heart rate is about 130, 140. In case you are trying to do a exercise stress echo less than 60 minutes, 60 seconds or 90 seconds period, the window is too small, and that rate, the respiratory rate is so high. I do a fairly good number of stress echoes, maybe 3 or 4 a day, exercise stress echo, but still I have not actually focused myself in looking at coronaries after the exercise. I think it's very challenging. I don't think so I'll be able to see. But I like to review that literature, ABCD, what you're saying. Let me see what percentage of coronary they could pick up after exercise.
They say that middle AD in that long axis view you can pick up. That's what seen in the literature. I have not also picked up many cases. Probably you are doing so many stress echoes. You should be able to pick up the
maybe I'll start looking into it. Sure.
Thank you, Dr. E.P. Singh, for your great lecture.
Thank you.
Over to Smit.
Sir, we have an adult echocardiographer here who routinely reports 3D vasculography, and then is it somewhere competitive or in comparison to coronary angiography?
I didn't get your question, sir.
There is one echocardiographer in my city who does routine 3D vasculography.
Vasculography means what?
Means he reports that, LAD is normal, LCX is normal, RCA is normal, or maybe diseased, and then sends patients back home instead of sending for angio. So I was just wondering whether, with all these, can we really pick up with surety?
I think we can surely not pick up with the 3D. That's very true, because what you're talking is the frame rate drops so drastically. Picking up coronary arteries on 3D becomes a bit more challenging. And if you're talking about the color, if you're talking about 2D, yes, you still can pick up few proximal coronary arteries on a 3D. But you have a limit that you can only pick up things in the proximal part. And that too in about 60% of the patients, which is good enough. But distal coronary arteries beyond the proximal LAD, you don't see. You really don't see, because they go through the curvature, and from there they go right angle and into the interventricular groove. You don't see the coronary arteries from a distal. This is the best bit we have. So I think probably we'll miss a number of patients of coronary artery disease if we start believing that I've seen coronary on echocardiography and the flows are fine.
another question is, sir, to pick up right coronary artery, malignant right coronary artery arising between pulmonary artery and aorta. So
But that's
again,
possible. That's possible. That's possible. But that generally we do it in a pediatric population when we have conditions like tetralogy of Fallot's or transposition of great arteries. There it's a kind of a routine to look at the coronaries and their pattern, which way they are going, are they going through. But adult, I think the disease itself is so rare. At least I haven't seen a case on echocardiography. I don't know what is the incidence on cath, but at least on echocardiography, I haven't seen.
probably, sir, we require CT angiogram rather than even coronary catheter angiography also. And lastly, sir, for IUGR patients, I think we should make it a mandate that we have to look for coronary artery disease in those fetuses.
Even if you don't want to see, they are visible. You'll see it.
That probably from your lecture, I could.
They become so prominent. They become so prominent. They are about, say, about a third of the size of an aorta. You would see it anyway. They'll be glaringly there. They would, and many a times, just we see coronary artery patient referred for a fetal echo. I had not done the detailed, anomaly scan or the Doppler of various areas to understand whether this is an IUGR or not. But we send the patient back for the same, that please look for IUGR if we don't find any other reason for prominent coronary arteries. And it's very common. It's very common. We see it about odd 5 or 6% of the fetal echoes what we do. And obviously with we get fetal echoes on a referral basis. They are not they're already positive or they're already abnormal, those who are referred to me. So, but 5 to 10% patients, we do see coronary arteries. About one patient I would see every day of a prominent coronary arteries.
There are any other discussions so we can have? Sumit, you have anything? If there are none, sir, it was an excellent talk, sir.
Thank you.
It is something that probably we have not ventured. We have even not even thought that these things are possible and happening. Other than for Kawasaki, I think I had never looked for a coronary on an echo. So this was great, and I think many of us would have now become interested in looking for few things extra than the routine, and it's not something very difficult. It's something just needs a little investment of time, and could be done, sir. Thank you for
Thank you.
and keep things, sir, to this class so that we have great discussion and we can look forward. Thank you, sir, and good night.
Thank you very much. Bye-bye.
Thank you, sir.
Thank you.